available to download or to listen to online on YouTube. If you're not speaking, we ask that you keep your microphones on silent. As webinars tend to be quite informal, you're more than welcome to keep your cameras on, should your bandwidth be sufficient for that. Presentations today, we have 2 presentations. There'll be a 30-minute...
If you want to ask a question during the question and answer session, just raise your hand, and then we can invite people to speak.
Michelle, can you not hear me?
You're breaking up.
Oh, am I breaking up, everyone? No, I think it's
I can hear you.
This is going to be confusing. If you just, if there is an issue, can you start putting your hands up and then Michelle will jump in? Because I can hear Michelle clearly, I don't know. Okay, so I'll carry on, but if there is a problem, put your hand up. Oh, everybody's saying I can hear you. Great, thank you. So after the 30-minute presentation, there'll be 15 minutes question and answer slot. Either put your hands up to ask in person or use the chat bar. If you do put your hands up and you're going to be asking the question in person, please give your name and potentially a job title if you want to, if it's relevant to your work. Everything this morning, both presentations are in English. If you wanted to ask any questions in Welsh, we are able to do instantaneous translation just on a one-to-one in that I'm a fluent Welsh speaker. Dwi'n gallu siarad Cymraeg a byddwn ni'n gallu cyfieithu, so I could translate for you. And that's about it, really. Has anybody got any questions, or are you happy to proceed? I think there's 36 in. We've got 70 registered, but a lot I know are just kind of dipping in and out as and when they can. And we're going to be relying on the recording afterwards. I can see that Shane is here. I'm going to make 2 announcements before we introduce Shane. You might be 5 minutes early, Shane, if that's okay. The first is to say that we've done these series of webinars now for a few years, and we do 2 a year. We do 1 in January and 1 in July. But as from the end of this month, hopefully, we're starting to do podcasts as well. So as you're on our list for communications, you will be getting an invitation to listen to our monthly podcasts if you're interested in those. If you don't want your name to be included, just ask us to unsubscribe when you get that. The other thing to mention is the conference. A lot of you have come to our conference in November. To confirm the dates of the conference this year are 14th and 15th of November. It'll be hybrid as previously, so it'll be available online and in person at Builth Wells. We're not restricted to numbers like we were last year in Builth, so there'll be more people in attendance. The call for paper and posters has gone out. If anybody's interested in submitting, please let us know. And if you haven't had an application, we can send one to you. The closing date is the 22nd of September this year. And I think that's all my housekeeping notices. I'm going to say, Shane, are you there now? I can see you're in the call group. Would you be able to start 5 minutes early?
Yeah, absolutely. I'll just switch on my camera, so bear with me 1 second, and I will be right with you.
That's okay. I can introduce you. So Shane Allen is with us. He's actually, it's quite an interactive. He's going to be giving us a demonstration from the BT Health and Care Innovation Showcase from the demonstration centre, and he can tell us more about that in a minute. It's the Research and Innovation Labs, so there's some quite exciting developments that they've got there. I'm going to unpin myself and pin Shane to the centre, and hopefully this is all going to work smoothly.
Yeah, if you wouldn't mind, if you spotlight my page, that should mean everybody gets me in full screen mode.
Is that it? Can you see yourself? You're in the spotlight now.
That looks good for me, yeah.
Okay, over to you.
So morning, everybody. As we said, my name's Shane. I'm going to be your host for roughly the next half an hour, and I'm here in Adastral Park in our research headquarters. Now, we're based in Ipswich in Suffolk, so across the other side of the UK from many of yourselves. But this, for BT, this is where the majority of our research and academic expertise sits. Now, one of the facilities that we have here that is, I think, a real crown jewel of BT is our showcase facility, which is where you can see me situated in right now. Now, the showcases, what we do in the showcases, we've got 9 environments mocked up to look vaguely like real world locations. So the one that I'm in is our health showcase, but we also have a bank, we have a defense zone set up to look a bit like a military base, we have retail, security, we have a home, we have all these different setups, and spread across each of those 9 environments, there's something in the range of about 350 technology demonstrations. Now, the idea of those demonstrations is they're a mixture of our own research, so things that we are working on internally that we think are potentially impactful or disruptive technologies that might be useful in industry or in people's lives in the future. Some of the things that we demonstrate in here are things that some of our partner companies that we're working with are bringing to life. And to be honest, some of the things in here we just think are really, really interesting. The key thing with all of the different demonstrations that we have in this space is that there's a network involved in some way, shape or form. Now, that might be a dedicated wired network, that might be wireless, that might take the form of 4G or 5G, Wi-Fi, could be a broad mix, but fundamentally every demo has a network involved in some way, shape or form. Now, the reason that we have the space is to showcase those technologies, to bring those technologies to life in these situational environments. So the health setting that I'm in, we'll do a little bit of a panorama in a moment, and you'll see that we've got, so as well as the back of the ambulance and the bed, we've also got, if we head over this way, we've got our mini care home setting. We've got the entrance to our GP practice / emergency services space. And then over here, we've got our GP practice, and then we've just got some broader presentation space. But the idea in this particular showcase is we're very, very focused on how technology can help in health settings. Now, we've not just got it as a showcase. This space is also fundamentally a space where we are doing work with NHS trusts and care trusts to see the technology solutions that we're developing and we're working with partner companies on, how can we practically implement them? So this is also a collaboration space where we have NHS trusts coming in here, and we look to find solutions and we look to trial this technology in real world settings. So some of the things that I'm going to show you today are things that we are actively trialing with care trusts at the moment. Some of them are research pieces and some of them are just interesting concepts that we're working on. As we go through, as you can probably already tell, I can talk for England. So if you don't interrupt me when you have questions, I will keep talking. So please, by all means, I don't know if people are doing it in the chat, I'm not going to see it. So if someone would be kind enough to kind of, from an admin perspective, just if anything drops in the chat, ask those questions. But also don't be afraid to switch on your microphone and just ask me a question live. I have some things in mind that we've discussed that we think are going to be appropriate to show to you. But if the conversation goes in such a way that you want to find out about something else, I can definitely move down that route. So please, by all means, let's keep that an open conversation today. Now, what I'm going to do, I'm going to start off with our 5G connected ambulance solution. Now, this is something that historically has sat in the back of an ambulance. So back in 2019, when we started this research, we were looking at the idea of what could 5G connectivity do in a medical setting. If we could give an ambulance, for instance, good connectivity, 5G connectivity over our public 5G EE network, what could that mean for paramedics, and what could that in turn mean for patients, and potentially for triaging, and potentially for the ability to have even a paramedic carry out a procedure that normally would happen in A&E. Now, the thing we focused on here, and this will be a really strange concept, but the thing we focused on was the use of haptic technology. So could we use 5G connectivity to allow a paramedic to transmit touch, so haptic feedback, touch feedback, live over our network without delay? Now, haptics is not a new technology, and I've got an example here of some haptic technology. So you're seeing here a haptic pen that is linked to the one that you can see on the lower screen. So as I move the one in the real world, the one on the screen is moving as well. When the one on screen feels resistance, so it touches one of the boxes you can see on screen, I am feeling that object here as if that object was physically in front of me. So right now I've got it clicked over the membrane, I'm feeling a squishy membrane. As I move to the vibrating one, the pen begins to vibrate. Effectively, every single touch sensation that I've got on that screen, I can actually bring to life remotely. So although those objects are not physically here with me, it felt to me just now as though they were. So we took that concept being able to do that live, and that's only possible over 5G, because doing it over 4G, you get about half a second's latency, half a second's delay, which is enough that the human mind can't correlate the physical movement to the reaction. So we took that concept, doing that live over 5G with little to no delay, and we applied that to a number of bits of equipment in the back of an ambulance. Now, the idea of the 5G connected ambulance trial was, could we augment the capability of the paramedic? So first off, the paramedic would wear an augmented reality headset. So the paramedic would pop that on. They could then share their view, so exactly what they were seeing through the cameras that sit either side of the lenses here. In the actual screen, in the visor, a remote person, a remote doctor, could feed in data that could overlay the real world. So as the paramedic looked at a patient, for instance, they could get information about that patient. Obviously, that allowed visual communication. We had verbal communication in there too, so the paramedic could communicate back to the doctor. But the key bit, and why I was showing you the haptic experience just now, was the paramedic would wear a haptic glove. So as they were carrying out some basic procedures with the patient, paramedic would wear this haptic glove. So exactly like you just saw in the back of the ambulance, except in glove form. So for instance, as the paramedic grabbed the wrist of a patient to get their pulse, the doctor, who was remote and wearing a paired glove, would feel that pulse in their fingers as if the doctor was gripping that patient's wrist. So the remote doctor could share that haptic experience in real time with real feedback. Now, what we then focused on was, okay, that's a useful thing potentially to be able to do, but what about some slightly more complex things? And the one we focused on was ultrasound. So ultrasound is a procedure that typically paramedics don't get trained in. A lot of them have these in the back of their ambulances, but given the time it takes to complete the course and the cost of completing the course, many paramedics don't receive that training. So we focused on ultrasound. If you could have that 5G haptic capability with that audio-visual communication, could a remote doctor guide the hand of a paramedic through the ultrasound procedure? And we were able to successfully prove that, yes, we could do that. And we did that in a clinical setting as well. And again, the key was we couldn't do that over 4G, but we could over 5G. And so suddenly, a thing that potentially a patient would go to hospital to have done normally, an ultrasound, instead, that happens on the road. That happens at the site of an accident. That happens at the site of wherever the ambulance ends up. And that I thought was quite an interesting way to go, and a really, really kind of exciting look at where 5G could be useful. But then I actually think we found a better use case for it, because when pandemic lockdown 1 happened, this kit went into a local care home, and residents in the care home, although they physically couldn't be in the same room as loved ones, we could remotely allow them to share the sensation of touch. We could remotely allow them to hold hands with a loved one and gain comfort from that experience over our network. For me, it's literally using connectivity for good. It's using the ability to have a person be connected on a network and share touch feedback in real time so that two people could hold hands. And yeah, okay, great to be able to do ultrasound, but to be able to have people hold hands, like such a simple thing, but such an important thing for me in terms of where that could have power for people. So yeah, so that was the form that took initially. The kit itself has now evolved quite significantly. So rather than the kit you've got here that would sit in the back of an ambulance typically, we now have a backpack equivalent. Now that backpack equivalent is about 9 kilos. It's got other capability built in as well. And we're looking at kind of virtual ward solutions as a part of this. But the overall thought is, could we have that be, if we look at a care home as a setting, could we have one of those stored in a care home? And in the event that we need to carry out some basic triaging and make a decision about whether or not a resident needs to go to hospital for some treatment, could a non-expert pop on the headset, pop on the haptic gloves, have a remote expert dial in and have them be guided through some simple triaging procedures, and potentially we avoid that scenario where that resident goes into hospital. And I'll give you a real world example of where that for me, I can see the benefit of that. So my nan is currently in a care home. She's 93 and she's very immobile, can't walk anymore. The act of transporting her to hospital for anything, and I'll give you a great example. She recently lost her hearing aids, both of them, and so she has to go all the way into the local hospital in order to have new molds done for her ears. They're going to have to transport her all the way into the hospital, and for her it's traumatic. There's a cost associated with it, but there's also a staff cost in that that one of the carers in the care home will have to go with her. And so actually that's one less carer in the care home looking after the other residents. Imagine with haptic feedback and with live video capability and being able to communicate verbally, maybe there's a future version where we don't need to travel. Maybe that doesn't need to happen like that. And you know, I'm stretching a little bit, admittedly, with the idea of an ear mold as an example, but with other more basic procedures, could we do that without the need to travel, without the stress and the risk and the problems that potentially come from that? And obviously, the NHS cost of kind of things like wound management per year is in the billions of pounds. So anything we can do that potentially alleviates that pain, I find very interesting. The same true with our virtual ward solutions, where we're looking at ways that actually we could have packaged equipment like this that could allow a patient to even potentially carry out some of these procedures themselves. So a backpack equivalent of what I've just been showing you there. Now, before I move on to the next demo, I'm going to do a quick pause and breathe moment and just check, are there any questions that have dropped into the chat? Anything that you'd like me to answer, or am I okay to move on to the next demo?
There's no questions there at the moment, Shane, although I was going to ask you, is this being trialled? You said
Yeah,
in
absolutely.
England.
This is
there
something that's
anything
being
in Wales
trialled
going
in.
on?
I don't know about specifically in Wales, but that's the nice thing about the showcase space. If any of you on this call see anything today that you're interested in, that might be something we could pursue. We could look at trials. So yes, if you see a use case for this, we could look at trialing this for real. And that is, again, very, very much the point of the showcases is you come in, you see a thing you think is relevant, we can go down the route of trialing this for you and seeing if this is a solution that you want to follow and see if that works for you.
If I could ask a question, Shane.
Yeah,
my
absolutely.
name's Tom Brooks, and I'm now retired. But 40 years ago, I did work at Martlesham, so
Brilliant.
I know a little about it. 5G particularly attracts me because it's the future for so many different things, and yet the progress in installing it in rural Wales is extremely slow, non-existent, as it were. Can you offer us any hope?
Absolutely. So we have an ambition to roll out across the whole of the UK within the next 3 or 4 years for rural areas where, for instance, it might just be too cost prohibitive to reach out to incredibly rural areas. We're now seriously exploring a number of solutions alternative to 5G, but which can provide the same kind of level of speeds and latency that you expect from 5G. So 2 great examples of that are satellites. So we have a number of partnerships that I don't know if I can name the names yet, but there's a couple of companies that work in the satellite space that we have partnerships with that, if they've not been announced yet, are very, very soon due to, in which we will look at using satellite provision instead of 5G rollout, where that might be a more appropriate thing. And for my money, from my experience of that, I recently had an event in a rural location, so an event called the Suffolk Show, a big agricultural fair here in Suffolk, and the broadband provision and the 5G provision in that venue was not suitable, and I used a Starlink terminal, and I was getting 150 meg upload and download. So for me, the satellite actually provided better than the Wi-Fi infrastructure could have provided. So that's one of the solutions that we're going down. The other is something we're looking at called HAPS, which is high Earth altitude platforms. Now, this is the best way to describe it. Think of a plane, but with really, really, really long wings. So in visual appearance, it looks like a plane, but the wings are just much, much longer in distance than traditional planes are. The idea of these devices, they're hydrogen powered. They can stay up in the air for about 20 days at a time, and they would have cell masts attached to the wings. And as they fly in low Earth orbit over rural areas, they would provide mass coverage. Where 5G might not be possible with a physical antenna on the ground, the HAPS platform is one of the solutions that, again, we've made some announcements about that very recently, that over the next year or two, we're going to start to deploy this stuff for real. So the solution for us is things like that. The other one is where rollout has been slow in a couple of locations due to being rural, maybe being difficult to access. One of the things we're looking at here at Adastral in our drones and robotics lab is the use of exactly those 2 things, drones and robots. So the robot provision, there's a number of different solutions that we're looking at. My particular favorite is a robot about this big, has a drill attached to the front of it that can autonomously dig beneath the ground at about 15 times the pace that a human can. So no more kind of road closures and things like that. The idea is the robot digs beneath the ground. As it drills, the sensors on the front can detect rocks and anomalous things beneath the ground. As it's digging, a 3D printer attached to the back of it 3D prints the ducting, which then also pulls through the shielded fibre so that we can do a complete fibre provision out to a premises, but without ever having to do the kinds of road closures we do at the moment. The final one on the drones front is that we are looking at things like, can a drone fly a fibre straight over a valley, where for us over a significant mountain range, it would be a case of climb down with the fibre, climb up with the fibre and risk damaging that glass fibre. Could the drone instead fly it straight over and we create a provision in that format instead? So yeah, we've got a number of solutions that hopefully answer that question for you around the things we're looking at to get that provision out to you, hopefully pretty soon in the next couple of years.
Well, it's encouraging that there are lots of sort of alternatives, and one of the things that we've learned in the last year with the troubles sort of in Ukraine is the extent in which cyber warfare has now expanded, as it were. And 5G did have the advantage of small cells, which you could use on security, which hopefully you'll have the equivalent on the others too. But I'll let other people ask questions.
No, I mean, absolutely to your question on that, 100% cybersecurity at the heart of everything we do. So yeah, absolutely.
You've got two people wanting to ask you a question here now, Shane. We've got Natalie, if you want to go first, and then Claire.
Hi, thank you. Yeah, my name's Natalie and I work for Signum Health in Wales.
Hi.
Although I'm based in Cornwall, I'm not Welsh, so I'm glad this is in English. My question, and I hope it's relevant for lots of people on here, is this is amazing, innovative technology, and I don't know whether you'll cover it, but with the trials and concepts, how are those funded? Because especially sort of in public health and other aspects, funding can be quite limited. So is there any support funding with these technologies?
Yeah, so absolutely. We go down a number of routes. So in the event that a customer has the funding to facilitate something like that, we would look to work down that route. We look to go down the partnership route where things are part funded by each organisation, or we go down the route of things like Innovate UK funds and potentially getting sponsorship to actually fund these trials. So my role sits within our networks and research strategy team in BT, and we're very familiar with the whole thing around getting funding for trials and things like that around whatever pots of money in terms of the innovation and research piece are available. So there's different routes that are available down different scenarios for a customer. So absolutely there is support for that kind of thing.
Amazing, thank you.
No worries.
Claire is next.
Hi, yeah, I'm
Hiya.
Claire and I work for Rural Healthcare Wales. There's just a couple of things. I live really remotely, and satellites definitely don't work around us. We've tried, we've invested in them, and they just don't work. The other thing is I've got quite a clinical background, and I just wanted to know about infection control and use between patients, whether you'd considered that and what were your solutions, because obviously like that glove is quite an expensive piece of kit.
Absolutely. So there's a number of things. So on the thing about the satellites not working, that's exactly why we're looking at other solutions as well, is because we're aware it's not always the right solution. So we have alternative provisions that we can do. On the thing about the clinical piece, absolutely. So the glove, yes, is something that clinically would need to be cleaned each time, and we've looked at various solutions around that. One of the alternatives that we found, and this is me changing my tack on the fly to show you this one. I'm going to bring us over here to show you this. So that whole haptic experience that I just mentioned. Just going to unplug this so I can bring it up to the camera. This unit here from a company called Ultra Haptics can do exactly the same thing, but in the air. So no glove required. So in this case, so the little sensor down here does hand tracking. So as you reach out to touch a thing on a screen and see a remote thing that you want to interact with, the unit up here that looks like a speaker doesn't blast up sound, it blasts up ultrasound. So as you reach on screen, where the physical experience would normally happen with a haptic glove, the ultrasound creates that in the air. So as your hand grasps a thing on screen, you will feel the resistance in the air from the ultrasound. So you get away from that need to actually even have the glove. It's one we're experimenting with, but potentially that is hopefully an answer to that question. The other thing, so the screen here is it's very hard to display on a video, so I'm not going to kind of show it in depth because you wouldn't get the value. But that's a 3D lenticular display that can make things appear 3D in front of you. So that combines with that haptics unit that I just showed you, and I know from a question from an NHS trust that came through the other week that that is certified for use in medical and clinical settings, and passes all the various requirements that are needed for that. So for things like being able to inspect a CT scan and things like that, that can be done in medical settings using those two bits of equipment, because we've absolutely got a use case where an NHS trust is looking to deploy that in medical settings already. So yeah, absolutely, that whole ensuring cleanliness and that we're meeting clinical standards is absolutely at the core of this stuff when we do this as well.
And the last question for now, before we let you carry on with your demonstration, Gabrielle, do you want to ask Shane?
Right. My name's Gabrielle.
Hiya.
I've got a professional background in health and social care, but I'm a social scientist. When you say, in answer to Anna's question about trialing, I take it that it hasn't been trialed with real live patients in a traumatic setting as yet.
I would say not in traumatic settings, no. But we've predominantly worked in kind of care settings, and there's a couple of smaller NHS trials that focus on some other things. I can show you one actually. I've got an idea of one that might be interesting on that front. But yeah, not necessarily in traumatic settings thus far. But that's something we would be looking to explore if there was an opportunity to.
Well, I mean, I think the technology is amazing, but I'm thinking about putting myself in the shoes of a patient who is in trauma, and just all the equipment which is necessary, you know, the headset and the haptic gloves and so on. I'm just thinking about the effect on a patient, and particularly your example of a care home setting where perhaps somebody is dying, but they're being told that they can hold a relative's hand via a haptic glove. I mean, I'm not absolutely quite sure, you know, how meaningful and what the psychological and emotional impact of that would be. So I think there's a whole lot of quite interesting socio-psychological questions around the impact from the user's point of view.
100%, yeah.
The other associated thing which relates to implementation is that, okay, you've got a paramedic on an ambulance in communication with the doctor. It will necessarily have implications for the contract, the paramedic's contract, because, you know, obviously there are all sorts of things that a paramedic is not empowered to do currently.
Absolutely, yeah.
So again, I'm thinking about the human impact of quite amazing technology. And I'm not expecting you to answer all those questions, but these are obviously questions that will need to be answered and need to be explored empirically further down the line.
Yeah, I completely agree. I mean, I consider this quite disruptive technology compared to things we're using today, and exactly that we have to get this right. I think is probably the fundamental. We've got to make sure that it's going to be a positive impact and not a negative impact, that it's going to be seamless and easy and simple to use. And that, I mean, with the 5G connected ambulance stuff, as an example, if we just shift the camera this way ever so slightly, so we've moved with the 5G connected ambulance kit to much smaller setup, for instance, that is much easier to use. And in this particular virtual ward solution from Fibris, we've actually taken the haptic piece out in the particular trial that we're doing because it was deemed too impactful in that case. We found it useful in other settings, less traumatic settings. So I mean, the one in the care home where we could have a loved one hold a hand was not a patient who was at the end of their life. It was a patient who, if I'm honest, it was my nan, and she was a bit distressed, and it was that ability to be able to do that. But yeah, we're looking at different versions of these technologies deployed in different ways in different settings, always with the patient being the core and the heart of that. Absolutely.
Okay, thanks, Shane. If you want to carry on with the demonstration, and we'll have questions at the end.
Yeah, no worries.
No
So
questions at the end.
I want to show you one that I think is a real potential game changer one, this one. So this is something called Wi-Fi imaging, and this is, I'm going to show you it in a home setting, but this could be in other settings as well. Specifically, the work we're doing and the research we're doing is for use in the home setting, and it's something we're, within the next 12 months or so, looking to turn into a service that we could offer out. And I think if we get it right, I think it has potentially lots of uses beyond the ones I'm just going to show you here. Now, the idea of this Wi-Fi imaging solution, so we've got a router over here propagating out a Wi-Fi signal. So just like your router that your laptop is connected to right now to be on this call, it's pushing out a Wi-Fi signal and we can connect devices to it. However, a lot of the signal actually gets wasted. So you've got maybe 5, 10 devices connected in your home. The rest of the signal is doing nothing. What we're doing is making that signal be useful. So over here on the left-hand side, we've got this blue box. This is a visualization of that signal. So this is something called a Doppler spectrogram. So think of it a little bit like sonar, like pings going out and being returned. And what that's doing from the Wi-Fi signal is telling me a person's proximity to the router. So the red and orange and yellowy blocks are actually a visualization of a person. And the middle bit here is us translating that into human readable data, so proximity. So as I hit play on the video and Emma walks away from the router, we see the red dot goes up in distance. As Emma then turns around and walks back towards the router, we see that that's going down in distance. Now, first question I usually get, why is she wearing a knee brace? It's completely unrelated. Emma had an injury 3 days before, dislocated a knee and still wanted to be in the video. It's purely the Wi-Fi signal allowing us to understand her proximity to the router. Now, if I jump the video forward a little bit, we see that we can do not just walking, but we can differentiate slightly more complex movement. So things like the difference between sitting down and standing up. So suddenly, if I'm thinking about my nan in a care home, suddenly I can see, is she active? Is she sedentary? Is she up and walking about? But the one I think has got the real potential is this one, fall detection. So what we see is Emma takes a fall and we get an immediate notification of that fall purely via the Wi-Fi signal. Now, I just think if we get this right and we get the ethics bit about this right, I think this one could be a bit of a lifesaver. In a home setting with my nan, that is the difference between her falling out of the night, falling out of her bed in the middle of the night and spending 18 hours on the floor, or we find out right away. Now, my nan, when she was living at home, we had the pendants, we had the wristwatches, we had all of those things. She wouldn't wear them, but she did have Wi-Fi because we had a solution, an in-home monitoring solution that relied on Wi-Fi. So the fact she had that meant that we could trial this system and actually see if that would be useful. Now, we've gone on into further trials with this now, and I think I said it just now, we're about 12 months away from this being an actual service we can offer. The bits that we're trying to make sure we get right are, one, who the data gets shared with, because in the wrong hands, it's people tracking. Also, just from an ethics perspective, like, do you want every movement to be shared? Well, probably not. The point of this is that there's no cameras in the mix. It's purely just on the Wi-Fi. So you're not seeing a person's movement. You're purely just getting that fall detection and that alert if something bad happens. The other bit around this is actually, if anything, lowering its capability. So it's good enough that it can detect not just in your own home, but further out based on how far your Wi-Fi signal propagates. So for instance, if we offer this as a service, we would look to have an engineer come and geofence your home so that actually we only track inside the bounds of your home, not your neighbours or out in the street. The implications for me with this are, yes, there's definitely a health thing here, right? Fall detection, huge potential importance. But actually there's a whole security stream with this as well, this is CCTV, but without the camera. And for me, I just find there's a whole interesting piece where if we get this right, I think it could be very, very powerful. And there's another version of that we're trialing as well. So we've been doing, if we shift round this way, I'm going to shift into the mini care home very briefly. There is a camera-based equivalent of this that we are trialing as well. So this one is currently in active trials with a number of care homes around the UK. And so unlike the Wi-Fi imaging, this one is camera-based. So there's a camera up on the ceiling, and that's what's creating the image that you're seeing there. So there we go. You get a little pan up and see a little camera up on the ceiling. that is producing the image on this large screen of me. And what you're seeing is there's a stick figure type effect being applied over the top of this. Now with this one, very conscious that it is camera based, which means there's an image involved. Unlike the Wi-Fi imaging, which was purely just the Wi-Fi signal and your interaction with it, this one is creating an image. Now in the trial that we're doing, the image is never leaving the camera. And that's where the stick figure becomes incredibly important, because what actually gets transmitted out of the camera is that, purely just that stick figure piece. And the tracking, much like with the Wi-Fi imaging, allows us to do things like if a person walks into a zone they're not supposed to be in, you can see that's gone red to indicate I'm in a no walk zone. I'll go into a poor lumbar position, and after a few seconds that will catch up, and there we go, that now says I'm in a poor lumbar position. Forgive me, I'm not going to jump on the floor, but if I was to, it would know I'd fallen over. So exactly the same concept, but just done in a different way. Instead of Wi-Fi imaging, we're doing that with the camera tech at the moment. That's one actively being done in, it is 12 care homes across the UK right now. Now, how am I doing for time? I'm very conscious that I talk a lot and fast. Have I got time
you've
for
got
any more
another
demos?
15 minutes. So I don't know if you're going to do your proto demo, are you, and something else?
We can absolutely go to that one next. Yep. So
Brilliant.
this next one, this big fridge-like device is a box called Proto. It's a device that, whilst it looks like a big hollow box, and that's kind of what it is, I think it does something a lot more powerful. Now, we've got it in this health setting for reasons that hopefully will become clear in a moment. But what the box allows us to do is hollow portation. So the capability to have a person be physically in one location and be virtually transported to another location. So in a scenario where we're not talking a trauma scenario here, we're talking maybe just having a consultation, maybe even just having a conversation with someone, you could avoid the need for a person to physically travel if that was going to be difficult, and you could transport that person elsewhere. Now, in our scenario here, you're going to see I'm going to walk into the studio. So as the camera pans back, you're going to see me walk into the studio. And as I walk into the bounds of the camera, you now see that I appear in that box as if I was physically there, and I've got 3D appearance and everything as well. Now on the studio side here, I've got an iPad that's sharing the view from the camera on the top of the box. So I can see you on the camera right now, and I can see the Teams call. I could have an earpiece in so that I could hear into the room as well. But the point is, the studio, although in this case is close, the studio could be elsewhere. And why we've got it in this health setting, so the conversation with a number of NHS trusts and GP practices right now is, what if the box was in the GP practice and the studio was in a care home, and a resident could literally be wheeled in their wheelchair? They don't have to put on any specialist equipment. All they have to do is look down the barrel of the camera, and they can then have that conversation with a doctor, with a loved one, that kind of thing. And the studio side is really simple. You just look at the camera and you start speaking, and that's it, just like a real world conversation. For me, this is like, so we're on a Teams call obviously right now. It's like Teams dialed up to 11, because it's a full body experience. And for some reason, that just seems to be more engaging than a Teams kind of head and shoulders type experience. The other kind of use cases we're seeing for this are things like training. So could you have a single person be in one location and beam out to multiple locations simultaneously? So yeah, you absolutely can do it with this tech. And on a number of occasions, I have physically beamed from our studio into our London offices to deliver presentations. I don't know if it appeared on screen or not, so I'll just walk back into the studio and show you, but there's also the mini equivalent here. So when I walk into the studio, there's actually a shrunken down version. So think Charlie and the Chocolate Factory's Mike TV, squashing that image down to a much smaller size, much more portable, much more ability to potentially have a person be transported to another location. And for me, the training type scenario is where the real big use cases for this are, and potentially remote consultation and remote conversations. I'll give you an example of where we found value in and use in this. So we've got a number of NHS trusts currently looking to purchase some of these from us, with a view that doctors could train other doctors. So when there's a conference on, rather than have that doctor travel out across the UK to different locations, could they actually just stay within their local residence, as long as they've got a basic studio functionality, so a clear backdrop, a camera and a microphone, could they actually be beamed out to other locations without the need to travel? Example for you where we've done this for real. So last year I lent the box out to Christie's, the auction house, and they had a Degas statue worth several £1 million that was due to go out to 5 closed envelope auctions. So the Degas statue was going to travel. There was risk of that. There was insurance costs. There were flights involved because it was traveling all over the world. What Christie's did in the end instead was they contacted 5 companies that had these boxes already, and they did 1 simultaneous auction instead of 5 closed envelope auctions. They're now claiming they got £20 million over asking price purely through the use of this tech. It effectively paid for itself in the first swing of the gavel. That for me is one single use case out of many potential ones where a person or a thing has more value in being transported virtually than in going for real. Anything, I mean, think pandemic scenarios where physically it was not possible for people to travel, you could still beam a person in. And yeah, this, of all the things that we show in the showcases, this one's the one that every customer is clamoring to buy from us, has use cases for, especially the small one, which I think is the one that will probably be the one that breaks into people's homes maybe one day. Yeah, for me, this is one of those future of telecommunications type things. This one, unfortunately, is an example of one that we didn't invent this one, but we have an exclusive UK reseller agreement with Proto, so we are their UK sales floor. So when a customer wants to see one of these, they come to one of our BT premises to see it. I'm genuinely convinced 4 or 5 years from now, a good chunk of us will have these in our homes. These will be in shops. These will be in commercial settings, and people will be using these for telepresence, telecommunications type purposes. I can just see it. I can see that this is the one that's the next level up from Teams as it currently is. This is the one that actually allows suddenly that next level. When you start to think about where that maybe combines with some of the other technologies I've shown you, the haptic type capability, suddenly there's lots of potentials here where this could be really, really interesting and really, really useful. So I'm going to pause there again. Any questions? Because I'm conscious that I talked a lot there.
Well, there's a question from Sarah. I don't know. Do you want me to read it out, Sarah? She's just asking, what can the person in the box see? For example, if you're doing training, you want to be able to see how the people are reacting.
So the person in the box gets a view out of, can we just pan the camera? The person in the box gets a view from these 2 cameras up here. So those 2 cameras, one of them is a standard webcam. The other one is a volumetric camera that can actually perceive depth. So you can actually get proximity and distance out of this as well. So on our studio side, we've got an iPad just because it's small and it's portable and it's easy. But it could be whatever you want. So it could be projected onto a screen of that size. So the camera feed can be as large as you want it to be. So yeah, you can still get that rich experience, much like you would on a Teams call, but in full body type equivalent instead.
Right, and then Fatma has asked, what are the key ethical challenges that could arise when evaluating these solutions with real patients, and how can they be overcome? Sarah says
by the way. Probably one of the biggest ones off the top is confidentiality, ensuring that any communication via these things is done in a completely secure way and only transmitted to and from the places we expect that to be done. Now, for us, that ultimately takes the form of cybersecurity, so ensuring that the packets of data being transmitted are done so in a secure way. We're currently one of the top 10 cybersecurity solutions providers in the world, with an ambition to be in the top 3. We have a number of managed solutions that help deal with that stuff. More broadly, from an ethical perspective, though, I think there's just a piece about how these technologies get used appropriately. So, I mean, the Wi-Fi imaging, my immediate personal feeling is that with Wi-Fi imaging, you wouldn't want to be observing a person all the time. It's the alerts for when a bad thing happens that we've trained it to spot, but also making sure that it actually does spot that thing reliably. So yeah, there's a whole piece here around ethics around how these things are perceived and used in the right way, and the training around how these things are utilized properly, and then just making sure that they are used in an appropriate setting is probably my personal view on that one. Hopefully that answers that question from my perspective, at least, anyway.
That's great, thanks. Has anybody else got any questions for Shane? There's a lot of technology there that you've just shown us, and it's a bit mind-blowing, isn't it? We kind of think, where's this going? And I know when I saw that proto demonstration, it blew my mind, and I thought, wow, are we going to be beaming consultants into all kinds of situations? But you mentioned it would be the patient actually via virtual reality.
But it could be the doctors, yeah, it could be consultants beaming elsewhere.
Particularly for rural areas where, everything's so far away. Amanda's got a question. Do you want to ask, Amanda?
Yeah, thanks, Shane. Fascinating. I'm the Assistant Director of Innovation and Improvement in Paris Teaching Health Board. There's a lot of talk about work with NHS trusts and community care trusts, which says to me England. What's your plan for coming to Wales? Because I'm sure there's a lot of health boards that would love to be demonstrating and trialling some of this.
Do you know what? Absolutely. And it's just a case of we've not yet had those conversations, but would love to. We're not limited to England at all. It's just we haven't yet had conversations with people who either have come in and seen this virtually like you are today or physically, or they just don't know about this. My biggest challenge in this job is getting this information, getting this technology shown and showcased out to as many relevant people as possible. So if you are a person that's interested in trials, if you know people who are, we're 100% interested in exploring that with you.
We'll be in touch. Thank you.
Brilliant.
I'll pass on your email address and contact details to the delegates after, if that's okay, Shane.
Yeah, and what I'll also share in the link afterwards is the link to our Health Innovation Hub, where you can join up and get some of this information specifically down the health vertical. So yeah, we'll share that with you afterwards as well.
Right. Are there any more questions before we close, Shane? No, I think you've stunned everybody into silence. Oh, hang on. Tom is back with a quick question.
I've been holding back to give others an opportunity there. The technology you've been showing, I mean, is in use in many countries of the world in different forms and various competitors, etc. And that's not proven to be the problem in deployment. It's been the soft skills of the users working with it, which has been the challenge. And in England, as you know, they commissioned a report from Eric Topol to develop those soft skills across it. And the philosophy there has been multiple projects, pilot projects where they're able to do it. Can you give us an idea as to how many pilot projects you're now involved in sort of in England, so we can see how many we ought to be doing at the same time here in Wales? Yeah,
I mean, this won't be exclusively in health settings and medical settings, but it's in the kind of hundreds kind of number annually. So we're doing a huge number of projects, and I would say I've made a point today of, with all of the technologies I've shown you, I've specifically picked them because my favorite thing about each of them is how easy they are. So if you look at Proto, you have a box, you have a camera, a light and a microphone, and you walk in front of it. With the haptic stuff, you either put on a glove or you plug in that and plug in the software, and you've got that air haptic experience. With the Wi-Fi imaging, it's a thing you've already got, just we've repurposed it. The Wi-Fi, just we're imaging it instead. So we've specifically looked at these as, we think, hopefully useful technologies because of their simpleness to implement and their simpleness for anyone to engage with and to use.
I'm sure that what you've done this morning will give a great deal of encouragement to lots of people. I would merely comment from my experience. Each of our health boards in Wales should be embarked at this point in time on 4 or 5 of these projects if we're to be in line with the rest of the Western world, let alone China. And it'll be good if you and your colleagues are able to make those interfaces with the Welsh Government to get us started on the track of catching up with the others.
I absolutely, really keen on that. And I will say we had a delegation from Welsh Government here just last week to come and see some of this stuff in person. So hopefully we're starting to change at that government level. Some get people to be aware of some of this stuff. But absolutely, those of you on this call today, if there's any way we can work together, we would love to.
Yeah, great.
There's lots of info going in the chat box. I think Richard is picking up. Shane, you'd be pleased to know. Great. People are keen to work with you. Sorry, Tom, to interject. Did that answer your question in full? Yeah. Right, I'm afraid time's run out, Shane, but thank you ever so much. That was really
worries.
interesting, and I'm sure everybody is going to take time to digest. If you want to put in the chat what you said, that you'd put the link to the demonstration unit.
Yeah, will do.
That'd be great, and we'll send people your contact details afterwards, and everybody will have the recording from today's event.
Excellent.
Anyway,
Well,
so
thank you everyone
pass
for
it
being
on.
such an engaging audience, because it makes it a lot more fun for me when I actually have a conversation rather than just presenting. So thank you all for being so willing to be engaged.
Right, thank you. Diolch yn fawr.
It's
Right, we're just going to do, Tom, your hand's still up, sorry. Was that a legacy hand? Yeah, it's gone. Okay, we're just going to do a quick Mentimeter. I mean, this technology seems a bit tame now after all that, but if you can all, in the chat box right at the top, I did put a link to Mentimeter. Can everybody see what's on the screen? So if you've got a smartphone or a computer, you can go to menti.com. It's menti.com. If you put in the code 35095316, and if you can score Shane's presentation, it's just for feedback purposes. If you can score that on the slide. I can't see anybody joining in as yet. Are you there? Brilliant.
Whereabouts is it in the chat?
If you go, it's right at the top, sorry, but if you go to menti.com and then use the code 3509, maybe Michelle or Claire, you can put the information in the chat box again, 35095316. There's 3 questions there for a scoring just for our evaluation purposes. Whether you found the presentation to be interesting or inspirational, if the topic was relevant to you personally or to your work professionally, and if you think that demonstration that Shane has just given to us now, if you think that will positively impact you or the work that you do. You can see the scores they're coming in. Right. A couple more seconds to finish that. I'll take the slide off screen, but you can carry on to scoring. We'll be using that same code for the next presentation as well. I think your hand's still up. Oh, it's gone now. There we go. So our next presentation today, complete change now. We've gone from high technology to social prescribing. So hopefully something for everybody, not too much of a contrast. The next presentation comes from Dr Simon Newstead from the University of South Wales, who's been working on a glossary of terms for social prescribing. Simon, I can see you here. You've got half an hour to do your presentation, and then maybe we'll keep the questions to the end of your session, unless you wanted to be like Shane. As Shane's was a demonstration, it was perhaps more interactive, but if you want to deliver your presentation on the work you've been doing, and then at the end we can have questions. Is that okay?
Yeah, that's fine.
Great.
Okay. Well, firstly, thank you very much for inviting me to present on the work that we've been doing. I'm not sure how it's going to compare to Shane's. That was pretty out of this world, some of the stuff that he presented. But if I could just share my screen, I'm going to begin with a presentation, and then we'll go on to a demonstration. So just bear with me while I share my screen. Okay. So can everybody see that? Okay. Just a nod, or okay. I'm gonna assume that people can see it. I can't actually see anybody while I'm
yes, we can see it. It's showing.
Okay.
Great, thanks.
Great. So yeah, so today I'd like to present on some work that myself and my colleagues at the University of South Wales and the Wales School for Social Prescribing Research, or WSPR for short, and our partners at Public Health Wales have done to identify the terminology associated with social prescribing, and then translate that into a glossary of terms to help clarify and standardize the language associated with it. So social prescribing, across the nations of the UK, there are various definitions and models used, but within Wales, it's described as connecting citizens to community support to better manage their health and well-being. And the model that we use is a cross-sectorial model that offers a no wrong door approach to entry. This is slightly different to the model used in England, which is very much based within healthcare. So the concept of social prescribing is relatively simple, but unfortunately the terminology that's used can be very confusing, which creates barriers to engagement for members of the general public, but also impairs effective communication, both between professionals working across sectors, but also sometimes within sectors and professionals communicating with members of the public. Whisper identified the need for a tool to help clarify the language associated with social prescribing and also standardise that language. And to this end, both Whisper and Public Health Wales committed to the development of the Glossary of Terms. So, as I said, I'm going to have this I'm going to present on the process that we use to identify the terminology and to develop the Glossary of Terms. And we've actually produced two versions of the glossary, so a professional facing PDF and a website. And I'll provide a demonstration of both of these. There are essentially two parts to the development of the Glossary of Terms. So the first part was the identification and categorization of the terminology associated with social prescribing. And this itself had three parts to it, or three elements to it. So one was quite a comprehensive scoping review. And in this, we looked at the peer-reviewed literature across the nations of the UK, and then the grey literature within Wales. And so we examined the title and abstract from over 46,000 documents and articles, looked at the full text from over 700, and ended up charting data from 205 documents, about a quarter of which were Welsh grey literature documents or articles. And from this, we identified 373 terms. Another element to identify the terminology associated with social prescribing was a group concept mapping study. So this is a consensus generating methodology, and this consists of three parts: a brainstorming task, a sorting task, and a rating task. So the brainstorming task, where individuals were given a prompt and asked to submit terms or statements in response to that prompt, was used to identify additional terms that might not have been captured within the literature, because we felt that it was important to make sure that the glossary contained the terminology that was used by the social prescribing professionals in Wales. So in this brainstorming task, we generated 120 statements, and then these were eventually, from these 120 statements, we got 49 terms. So we also had numerous rounds of consultation. This was with a social prescribing coordinating group made up of various professionals across Wales, and that group was established by Public Health Wales. We also consulted with members of the Whisper steering group. So if you're not familiar with Whisper, it's a virtual all Wales school. And we have over 350 members at the moment, I think. And these members consist of researchers, social prescribing professionals, and government officials. And we also have links to three 3 communities of practice, 3 social prescribing communities of practice. And the additional rounds of consultation was with various social prescribing professionals across Wales. So this was sort of an iterative process. And from this, we identified an additional 41 terms. Some of the terms were excluded, and in total we had a list of 426 terms. So I should say, actually, the consultation process was also used to help define the inclusion and exclusion criteria for the terms for the glossary, and divide those terms up into 2 categories. So we had non-core terms, so those that are associated with but not specific to the practice of social prescribing, and then core terms, so those that are specific or essential to the practice of social prescribing. And the development of the glossary focused on the core terms only. So we had a list of 192 core terms and 234 core terms. So with the scope and review, as I said, data was charted from 205 documents, 373 terms were identified, as well as recording the terms that were identified within the literature. We also recorded the location of the research or intervention that was described within the literature and the perspective from which the article or document was authored. So we found that 80% of the terms occurred within the peer-reviewed literature, 30% of the terms occurred within the grey literature of Wales, and there was a 10% co-occurrence across both sources. So while there are some similarities across the 2 sources, there are some quite distinct differences in the terminology that's used across those sources. Additionally, when we looked at the location of the research or intervention that was described within the articles and how that coincided with the terminology, we found that the largest proportion of terms that we identified were from articles that described research or interventions within England, and then the second largest were those that were UK-wide. And the UK-wide documents were predominantly reviews of some form or other, usually systematic or scoping reviews. And then again, when we looked at the perspective from which the articles were authored and how the terms coincided with that, we found that the largest proportion of terms occurred within articles that were authored from a health and social care perspective. This was the same for both the peer-reviewed literature and the grey literature, but within the peer-reviewed literature, there was very little representation of terms from articles that were authored from the perspective of community and voluntary service organisations or the third sector. However, within the grey literature, there was quite a large proportion of terms that were authored from that perspective. I think it was approximately 40% of terms within the grey literature occurred within articles that were either solely or partially authored from the perspective of the third sector. So that itself raises questions about the representation of those who deliver social prescribing within the peer-reviewed literature, and also potential barriers to third sector organisations in publishing within the peer-reviewed literature. Yeah, as I said earlier, over 400 terms were identified, and focusing on the 192 core terms, the second element of development of the Glossary of Terms incorporated the other elements of the group concept mapping study, and these were used to help identify the relationship between terms and the strength of the relationship between the terms, and also the second stage was essentially, it was grouping the terms and identifying the relationship of the terms. And again, we used consultation for this. And this process allowed us to produce a consolidated list of 36 terms from the 192 core terms. So if you just take a quick look at the group concept mapping study, I'll try and explain it a little bit better. So we had a sorting task which used those 192 core terms that I mentioned, and we asked social prescribing professionals to group those terms in a way that made sense to those, sense to them. And we also asked them to provide labels for those groups. So we used a software called Group Wisdom, and this essentially generates a map of how the terms are grouped by everybody, and identifies the strength of the relationship between those terms and the groupings of those terms, and produces the diagram that you can see on the right. So the terms were most effectively grouped into 6 clusters, with the cluster principles underpinning social prescribing systems ranked the highest in the rating task, which I'll describe in a second. The other 5 clusters were names for social prescribing systems, related or complementary partner schemes and activities, environmental and arts and social prescribing assets, connecting to the community, and then roles in social prescribing. So you can't see it in this diagram, but within the software you can go in and you can examine each of these individual points and establish the relationship with other terms within the map, and the strength of that relationship. So that's essentially what we use the sorting task for, to establish the relationship and the strength of the relationship. And then the rating task we used to identify the importance to social prescribing professionals, not just in general, but by sector. So part of this study included the collection of demographic information, and part of that was the sector within which individuals worked. So we were able to relate that back to the demographic information and establish which terms were most important for which sectors, and then we cross-referenced this with information that we had from the scope and review in the production of the glossary. So most glossaries are simply a list of 25 to 50 words, often with no accompanying description. In the case of social prescribing, this isn't particularly useful. Unfortunately, the scale, the number of terms, and the complexity of the relationship between the terms necessitated a different approach. So as I said, we were able to consolidate the 192 core terms down into a list of 36. We call them suggested terms because we don't want to dictate what terms people should use. It's more of a gentle push in a direction. But unlike other glossaries, each of these terms is accompanied by a description, and also, where relevant, a list of alternative terms. And within that list, we've identified the sector-specific preferences for terms, and then the relationship of those terms to other terms within the glossary, to try and help the user build up a mental map of how the social prescribing terminology relates to each other. I was hoping that both the website and the PDF would have been launched by now. It was meant to be launched on the 7th of July, but Welsh Government have pushed this back to October this year to coincide with the launch of the National Framework for Social Prescribing. I think they're planning a big launch day where everything will be revealed. So it would have been nice to give you the link to the website and share the PDF with you in the chat, but unfortunately I'm not allowed to do that, but I will show it to you. So the first the first glossary that we produced was a professional-facing PDF, and that itself is interactive. But to increase accessibility and usability, we also translated that into a dedicated website, and this has several advantages. One is that the user will easily be able to switch between English and Welsh. And the other is that we've been able to come up with different versions for different target audiences. And again, the user can easily switch between those. So we have the professional view that uses the terminology and the descriptions from the original PDF. And then we've also produced a public view that has a more sort of a lay language used in the descriptions. And we're also in the process of developing an easy read version with Learning Disabilities Wales that aimed at individuals with learning disabilities. Another advantage of the website is that it will facilitate data capture and dissemination of updates. So the terminology associated with social prescribing seems to be evolving at quite a rate. This is the first time anybody's attempted to produce a glossary like this, and also the first time anybody's attempted to produce a comprehensive glossary or overview of all of the terminology associated with social prescribing. So it's likely in the future that it's going to require updating. No doubt once the website and the glossary are made live, we'll be able to capture a lot of data about who's using what sort of terminology, whether we got the descriptions right, for example, and some of the sector specific preferences right. They may need to be updated in the future. So the website enables us to track that data, but also for individual users to submit feedback on the website itself, and what they think should be included in future updates. So if I can just stop sharing my screen, and I will share it to a different screen, and I'll be able to show you the PDF. So where's it gone?
While you're getting that up, Simon, there was a question asking, are there any plans for it to be for a British Sign Language version? That's from Anne Silman from Betsy.
Oh, yeah, we haven't got any plans for that. But one of the questions in the feedback form for the website is how we can increase accessibility, and whether there are any accessibility requirements that we haven't considered. So I'll make a note of that, actually. If we've got enough time before it launches, that would be a good addition. Okay, so the first thing I'd like to show you is the professional-facing glossary itself. I'll just make this a little bit bigger, just so people can see it a little bit easier. So as a professional-facing document, the Glossary of Terms is prefaced by an overview of the research that has been undertaken to produce it, and the aims of the glossary. We've got instructions on how to navigate the glossary, and then we've also included a pathway diagram. So this includes each of those 36 terms that I mentioned, and sort of displays how they relate to each other within the social prescribing pathway. And this is interactive. So you can click on a term and it will take you to the appropriate description. Social prescribing practitioner. So we have a superscript key up here just to identify where the evidence for both the terminology and the description have come from. So in this case, consultation, the GCM study, and the scoping review. We have the description itself, and then within the description, there may be links to the other terms within the glossary. So if it's underlined in blue, it will take you to the appropriate place in the glossary. Below that, we have a list of the alternative terms that we've identified for social prescribing practitioner, and the sector-specific preferences are indicated again by the use of a superscript key. So we identified that the term community connector was the preferred term within the third sector, community coordinator, the preferred term within social care, and then link worker was the preferred term within healthcare. And underneath that, we have a list of connected terms, and each one of these would be one of the 36 terms within the glossary. So again, you can click on it and it will take you to the appropriate place within the glossary, and then you can easily navigate throughout the glossary, either back to the flowchart, or we've incorporated a navigation table. So this is just simply a list of all of the 36 terms. And again, it contains, I think they're called hyperlinks, and it takes you where you want to go in the glossary. So if I can now show you the website that we produced from that, and then I'll talk a little bit about the terminology, the 36 terms that we've used within the glossary. So this is the website. To use it, people have to register. So it's going to be free for use across the world. We did consider making it free for use only within Wales, but we've had quite a lot of interest in the glossary and the website from, I guess, from other people in other countries. So from the World Health Organization, for example, from the equivalent of Whisper in England, NASP, if you're familiar with NASP, National Association for Social Prescribing, and also from equivalent organizations in Germany, Austria, Singapore, Canada, the States. So it seems to be generating quite a lot of interest. So for that reason, we've made it widely available, so we can capture as much data as possible, and then hopefully we'll work with those partners to develop their own culturally relevant versions of the glossary. So on the homepage, you have a very brief description of the glossary of terms and why you would need it. And we've also produced an animation. I have tried sharing this in presentations before, but it never goes well. Apparently, it's a bit glitchy for the end user. So what I'll do is I'll put a link to the animation in the chat afterwards. But this is, please bear in mind that this is a draft animation. Towards the end of it, there's a section where they pan in on somebody's phone. Eventually, you will have a sort of a video within that, sitting within that shows how the glossary works. That's not quite there yet. So if you're not a registered user and you click on the glossary of terms, it asks you to either log in or to enter your registration. So we've included a number of questions to try and identify who's using the glossary, their level of current social prescribing knowledge, how they might think they would use it, and then accessibility considerations. So it's relatively short, but once you've registered, then you can just log in. You can just put your email and password and log in, and you'll get access to the glossary of terms itself. So we've displayed the terms slightly differently on the website because it's just allows us to do a little bit more. So again, we have the list of the 36 terms. You can click on each of these and it will take you to wherever you need to go. So it's relatively similar, but a couple of differences are that you can switch between the professional and public view. So we haven't got the Welsh translations up yet. Still waiting for Welsh government to get back on us. We're having a bit of a debate about a few of the terms that have been translated into Welsh. But if you switch to public view, the description changes. So it just uses language that's a little bit more accessible to the general public, but everything else is the same. So we still have the list of alternative terms. We still have the list of connected terms, which link you to the other places in the glossary. But beneath each of the list of connected terms is a mind map of the connected terms. And I appreciate that this is a bit big. We're currently working on making these smaller and uniform across the site. So you can click on, this is also interactive, so you can click on it and it will take you to the appropriate description, each of which has its own specific mind map showing you how it connects to other terms. And if you go to the Glossary of Terms page itself, there is a mind map that produces sort of a simplified pictorial representation of how those terms connect to each other. Additionally, we have the pathway flowchart. Again, this is interactive, so you can click on each of these 36 terms and it will take you to the appropriate place in the glossary, and you'll see the description, and then you can switch back to public view. That's a glitch. It should stay in public view if you're in public view. And then, as I said, if there's a term in the description, you can click on that and it will take you to the appropriate place. Yeah. Yeah, so at the moment, sorry, it's switching back to professional view, but then you click on, it should stay in public view when you're there. So there's a few little kinks still to iron out. We've also included a list of all of the 192 core terms that we identified. So every one of those is in some way represented within the glossary. So you can either search for a term up here, or you can come to the list of 192 core terms, and you can click on it, and it will take you to the appropriate place in the glossary. Here is where we're going to include the publications associated with the glossary. So we have an article under review for the scoping review. There's also going to be an article for the GCM study, and then an article that's about to be submitted that describes the development of the Glossary of Terms in its entirety. And as well as that, we'll have the PDFs of the easy read version, the public facing version, and the original professional facing version. And then we've included a way to provide feedback as well. So it's relatively simple. You just click on the button. You're already logged in. While the feedback is essentially anonymous, it allows us to cross-reference that with the professionals, the sector that people are using it. So whether you're a member of the general public, or whether you work in the healthcare sector or third sector or social care sector, we have cross-reference it with that information. So yeah, it just allows us to capture some information, both for upcoming impact case studies, but also for the development of the glossary in the future. And so that's it. So if I can go back to the Glossary of Terms and just talk about some of these terms. So some of these terms require some consideration, because it was quite important for us to represent the terminology that was used within the social prescribing workforce within Wales, which is slightly different to within England, but also to make sure that the terminology that we used didn't alienate the people that we were hoping would use it. So hopefully it will be used by everybody, whether you're a manager or a commissioner or a social prescribing practitioner or a member of the public or a GP. You can use this as a reference tool. But there were a number of considerations. So one thing that came up in the consultation for the National Framework for Social Prescribing was that people don't like the term prescribing in social prescribing. So there's quite a lot of resistance to it, but it is internationally recognised, and it is also one of the only two terms that were identified across all the nations of the UK in the scoping review itself. So for that reason, we've opted to keep social prescribing and use that as an umbrella term to define, to describe a pathway to connect citizens to assets in the community to improve their well-being. And similarly for social prescribing practitioner, if I can just click on that briefly. So I mentioned that the preferred term within the third sector, which within Wales is where social prescribing predominantly sits, is community connector and community connection. But the term that we identified as the most prevalent term in the scoping review was link worker, which is perhaps not surprising given the large number of articles that were from the health and care sector and from England itself. So again, we've opted to go for social prescribing practitioner as an umbrella term, whilst identifying the sector-specific preferences. So I guess our hope is that we're not alienating everybody, and we're acknowledging that these different terms exist and that there are preferences across sectors, but we're not within the glossary trying to stipulate a use of a sector-specific preference universally. But because everybody hates the term, not hates is a strong word, sorry, because there is a lot of resistance to the term prescribing, we've opted to try and unify some of the terms with the term referral. So some terms such as exercise on referral or education on referral already existed, but we've taken this opportunity to change green prescribing to green referral. So green prescribing still exists within the description. So as you can see, it's we still have it there. There should be, oh, that's public. Professional, yes. So green prescribing still exists as the preferred term within healthcare, but we've opted to use green referral as the suggested term for the glossary, and similarly blue referral and the umbrella term creative referral that describes activities such as dance on referral or art on referral. So some considerations have been taken to try and represent the terminology that is used by the social prescribing workforce within Wales, but also to, in some instances, to tweak it to make it more standardized and more acceptable or palatable to everybody. I think that's probably my time for the in terms of the presentation. Does anybody have any questions about that?
There was a question in the chat box, Simon. Have you linked with the National Association of Link Workers?
No, I don't think we have linked with the National Association of Link Workers, unless it was through Whisper.
I think they're based in England, aren't they? But I think they do try and cover Wales, but they're not as relevant perhaps in this country.
Yeah. So we have been in contact with the National Association of Social Prescribing in England, and they're keen to do some work to either produce a culturally relevant version for England, or to perhaps have a link to this on their website and incorporate the use in England over there.
Is it all right to come in on this one? Sorry, I just raised that one and I thought
Yeah.
it was good. Yeah. Being in Cornwall, I am English, so that's why I've put that on there. But I used to be a manager of a social prescribing team. And the National Association of Link Workers do an awful lot of work in standardising the approach. And I think it's fantastic that there's a glossary of these terms, although I may not necessarily agree with the referral and prescription bit. I think it's fantastic that this work's coming out. And the National Association of Link Workers really embrace and drive change. So I think it would be amazing if you could link up with them, because they have over 100 members of link workers, social prescribers, whatever you want to call them. So I think it would be really good if you could, because I think it needs to be a standardised approach across England, Wales, wherever really. So yeah, just a little, if you can collaborate with them, it would be amazing.
Yeah, no, thank you. That's really helpful. I mean, first and foremost, this was developed for use in Wales. I appreciate that we do need a standardised approach across the UK, but yeah, the work was done part funded by Public Health Wales and performed in collaboration with Public Health Wales and Welsh Government. So the initial aim was to produce a glossary of terms for social prescribing in Wales, with the hope that it would be able to be used across the UK, which is a tricky balancing act, because yeah, I didn't really describe it much when I was talking about the research, but we did find some very distinct differences across the nation of the UK in terms of the terminology that was used. I mean, a lot of it did come from England, so in a way, it's kind of telling that even the small representation that we got from the other countries had its own different terminology that wasn't occurring elsewhere. I think, yeah, I don't know what the answer is moving forward. I think we have to sort of put it out there, make our stand, or present what we've got, and collect the feedback, and then work from there to try and make it more unified. As at the moment we just don't have the data to produce one for the whole of the UK without not adequately representing the terminology used by the workforce within Wales.
Becky's got a question for you as well. Thanks, Simon. Becky.
Oh, hi, thank you for a great presentation. My name's Becky, I work for Rural Health and Care Wales. I was just curious, looking from the general population perspective using the tool, and whether you'd researched the alternative terms that might be sort of endemic to the Welsh population. So rather than just doing a literal translation of the terms that you found existing in Wales that were in English, whether you found many that were sort of community generated or population generated that existed in the Welsh language and were used.
Okay, so for the Welsh translation went to consultation with members of the Welsh public. So that was performed in Bangor with Gweminar Spencer. I don't even know Gweminar Spencer. So I think they had 12 people that went through the glossary and came to a consensus on the translation and the terms to be included, and then that's now gone back to Welsh Government, who they have their own process that has to be adhered to. But in terms of actually going out into the Welsh community and asking for or trying to identify terms that are used by members of the public, for example, in Welsh, we haven't performed that. But we're hoping that once the website is live, people will be able to submit that feedback, and we'll be able to collect that and collate that and analyse that over the next 12 months. So our aim is that 12 months after the launch, there will be a new version. So it may have less than 36 terms in it, because we appreciate that 36 terms is still a lot. A lot of these terms are not going to be, they don't really relate to the core aspects of social prescribing, but we were trying to make it as accessible to everybody that's involved in social prescribing, and as I said, used by managers and commissioners as well. So we've incorporated all aspects of social prescribing within this glossary, but depending on what the data shows, maybe it will, the number of suggested terms will go down, and then the terminology, the alternative terms that we've identified within there will go up, and the sector-specific preferences may even change. But yeah, it's a good point, because the terminology used by the general public, both in Welsh and in English, might be different from that we've identified in the literature and from social prescribing professionals. But yeah, I'm hoping to use the website as a tool to identify that.
Language is a living entity, isn't it? And even established languages evolve and mutate over time, whereas this, in effect, is a new language. So I'm sure there will be several adaptations to it as time goes on, and at least you've allowed for that, haven't you? Within the glossary, you've allowed for the two-way feedback and development.
Yes, yeah, I think probably we need to include something in the introduction to that, or the homepage of the website, so that people understand that, you know, that we produce this, but really this is the first step. So we're setting our stall and collecting feedback using the website that's there, hoping to you know, improve clarity with the information that we're providing, and standardize the language, but also collect additional information so that as the language evolves, or you know, we're fully aware that we have probably missed a lot of terms, so even not necessarily evolved, but terms that we haven't captured get captured, then we can develop it.
Yeah. Has anybody got any questions? I can't see any hands up, but I do have a question. If not, it's a great piece of work, because social prescribing and the word, like you said, social prescribing's caused a lot of issues, and I think it's a barrier in lots of respects, but you've got to start somewhere, haven't you? And I think what you've done is help clarify a new area of non-medical interventions that's going to obviously grow in the future and hopefully become standardized. But how does this work then? My question is, does this work fit into the national framework that's been developed by the Welsh Government? Because I know the University of South Wales is heavily involved with that as well. Does this glossary then seamlessly align with the national framework? Is it going to be adopted as part of that?
Yeah, so it's already referenced within the national framework, and the terminology and the descriptions that are used have been used to inform the development of the national framework. So the two have been produced in conjunction with each other.
Right, and Catherine Thomas has got a hand up as well.
Yes, sorry, just a question, whether or not the terminology differs in terms of referring people with known illnesses or comorbidities, and maybe in terms of improving health, to those that are preventative and want to keep people healthy. So sometimes the term social prescribing excludes those people that are healthy currently, but in order to maintain their health need to do certain activities or keep well, and to preserve their well-being.
Oh,
Does that make any sense? Because you know,
I think so.
Yeah.
I'll try and answer it, and then if I've got the wrong end of the stick, please correct me. So the description of social prescribing that's used in the glossary is very very much accessible to all. So it doesn't matter whether you have a long-term health condition or whether you have or whether you're healthy. It essentially describes a pathway that anybody can use to engage with activities and services within the community to improve their well-being. So, but it does involve referral. So you can either self-refer or...
I suppose what I was more saying is, do you think that that is a barrier? Because people who are well, they see a prescription for something that is wrong, so they think I don't need it or want it because it is something that I don't currently need. That's what I'm asking you. Do you see it?
Okay.
That terminology is a barrier to people who are actually currently well, but may have be potentially at risk of developing diabetes and high blood pressure because of perhaps other things that you know they could improve upon. Do you think that that terminology is a barrier to a specific group of the people that you're trying to reach, is what I'm saying? I understand that the terminology is broadly accepted, but I'm talking from a personal perspective, and I spoke to my sons, both sons, about social prescribing, and they said, well, we wouldn't need it because we're fit, healthy young men. Yes, they are, but they're both at risk of developing, you know, there's a potential for heart disease because it's a familial problem with us, and yet they see themselves as excluded because they are currently fit, well individuals. However, they do need to keep active and to keep involved and to understand what's available to them in the community to keep their health at its optimum level.
Yeah, no, I agree that it is a barrier. I think there was quite a lot of debate about whether we should adopt the term community connection in terms of social prescribing, but in the end, it has to align with Welsh policy as produced in conjunction with Welsh Government, and also because the term social prescribing is internationally recognised, that is why we've kept it as an umbrella term, essentially. But you're right, it does create barriers, and I think part of the work of the of making the glossary of terms known will be increasing awareness of exactly what social prescribing is and who can access it and who can use the glossary, but that also extends to everybody else, to policymakers and those that deliver social prescribing, to make sure that the terminology isn't a barrier and that people are aware that even though it does have the term prescribing in it, that it's not necessarily health-based or aimed at individuals who are sick or have long-term health conditions.
There's a huge cultural issue there, isn't there? And that's another ball game, if you like. But this, I suppose, is a small step in addressing it, in at least making sure everybody has a means to gain an understanding of this relatively, not alien, but new vocabulary that we're now adopting within health and care.
To be honest, our job would have been a lot easier if they'd adopted community connection right from the outset, and then I think that would have solved a lot of debate going forward and made it seem a lot more accessible to everybody. It's community connection and community navigation, I think, describe the process a little more accurately than social prescribing.
Sorry, Catherine, you've got your hand up again.
I think that social prescribing is a necessary term when people do have health conditions that would be benefited by the ability to prescribe certain things. So I think there is a need for people to understand this is a prescription that will benefit them in the same way as a medication prescription would benefit them. But in terms of preventative treatments, I think there may be the need for a different term for when you're addressing a different client group that you want to keep and maintain their health, rather than give them a prescription when something is actually wrong. That's the point I was making. So rather than there being one umbrella term that everybody uses and understands, that they to prevent exclusion or a different terminology in the preventative side rather than in the side where you are actually trying to provoke an improvement in the health. Yeah.
Yeah, within the description that we've included in the glossary, it does say that the term prescribing is a bit of a misnomer, because it's not, especially within Wales, it doesn't involve somebody telling somebody else what to do, which I think is, if you go to a healthcare professional, usually you're expecting to be told you should do this to improve your health, and receive a prescription of some sort. So, but social prescribing within Wales, especially, it's more of a collaborative, holistic approach that, so people, even if you go to a GP, it's not really social prescribing if the GP says you have to go and do this to improve your health. So it's more social prescribing if says these things are available. We'll put you in touch with somebody who can have a what matters conversation with you. You know, spend some time really finding out what the issues are, because you know, a lot of people present to GPs with some issues, you know, multiple times, but then you actually find out that the underlying issue is maybe isolation, you know, concerns about tenancy or something like that. So, and you don't really get that within your 10 minutes of the GP setting. It's just not feasible.
They reckon that, don't they, that 20% of patients who visit their doctors go there for non-clinical reasons, for social reasons. I'm sorry, I'm going to have to bring it to a close there. Thank you, Simon.
Okay.
Are you happy for us to share your presentation with everybody?
Oh, yeah, yeah. I'll send it. I've got an updated version, so I'll send you that after the meeting. And I've just put a link to the animation that I mentioned in the chat, so feel free to watch it, but be aware that it is a draft. So
okay. And you said the launch was going to happen in July, but you said the website has been launched in October now, so the glossary itself has been launched in October, is it?
Yes, yeah, both were meant to be launched on the 7th of July, but it's all been pushed back to October now, so that we can do a launch in conjunction with the national framework for social prescribing.
Brilliant, thank you. So thank you, Simon. We're going to go on to the painful Mentimeter bit, if you wanted to disappear. So if everybody again could go on to Mentimeter, it's the same reference as before, so I can get it. So it's menti.com and the code number 3509. I think a lot of people have already been on and been scoring, which is great. So if you can just go on and put your scoring in there, and if you found Simon's presentation interesting, whether the topic was relevant and the information would have a positive impact. And the reason for doing this isn't to judge the presenters, it's for us, it's an internal process for us to know if the webinars that we're putting on are of value to the people who are listening, and if not, you know, let us know. Great. Catherine, have you got your hand up again? Sorry.
Oh, sorry. So
that's all right.
Oh, did I?
I don't know, I just saw a hand coming up on my screen. Just to thank everybody for coming today, and just a quick reminder of those who weren't here in the beginning, we are starting a series of podcasts very shortly. You will, if you've been on this mailing for today, you will be sent information on it. If not, you want to put your email address, I either send it to myself, Michelle, or Claire at Rural Health and Care Wales. We'll make sure that you're included so we can send you information on those. If anybody's got any particular hot topics that they would like to see in our next webinar podcast, again, please drop me an email. I shall drop my email address in the chat box now. And then finally, just to remind everybody about our conference, which is our annual conference, which is taking place in hybrid format in Builth Wales on the 14th and 15th of November. And the call for papers and posters is out now. If anybody, thanks Vanessa, if anybody hasn't had a call for papers and would like to be included, again, please drop me a line and we'll send that out to you. The closing date for the papers and posters is 22nd of September. Thank you, Natalie. Please use the chat box, and that brings today's session to a close. Thank you all very much for attending, and we look forward to seeing you all soon. Diolch yn fawr i bawb. Diolch. Ta-ra.
Thank you.